I know most people here, I think, but for those of you who are here, if you could let us know in the chat your name, your organization, and what county you're in. We're just trying to keep good track of who comes to the coalition meetings. Ryan is letting some more people in. Great. People still trickling a little bit. Yeah, so welcome everyone. Thank you so much for joining us for our August meeting. If you haven't already, if you could drop your name, your organization, and what county you're in over in the chat. We're just trying to keep track of folks that attend the coalition meetings. And I'll repeat that message in the chat a couple of times over the next few minutes, so people will be reminded to do that as they come in. And of course, we always love to see your faces. If you can keep your camera on, that's awesome. But if not, that's fine too. We're happy you're here either way. Ryan, do you want to pop over to the next slide?
Let's do it.
All right, thank you. So we have a few objectives for today's meeting. We are going to do some exciting stuff in terms of unveiling our new logo and branding for the West Virginia Food as Medicine Coalition. I'm going to do a little bit more relationship building by learning about some more of our food as medicine programs that are happening around the state. We're going to talk a little bit about community care hubs and how they may be potentially relevant to the food as medicine space in West Virginia. And we're going to share our draft agenda for the September in-person meeting at Stonewall and invite some feedback on that. So we've got a packed agenda. If you want to move over to the next slide, Ryan. So yes, welcome. If you haven't joined us before, we would love for you to raise your hand either by using the react function or turn your camera on and raise your actual hand. So yeah, this is our agenda, just a bit of a recap. We're going to debut our logo. We're going to spotlight one of our food as medicine providers, Pharmacy West Virginia today. We have Mark Humawicki from the Camden Coalition giving a presentation on community care hubs. And then of course, we're going to share out our agenda for our September meeting before we wrap it up. So welcome everyone. Thank you again for joining us today. And I'm going to turn it over to Miranda.
Hello, everyone. We're happy you're here. Good to see everybody. So you guys are gonna get to see the logo today, which we're really excited about. So thank you for everybody that voted. We had to do a very short turnaround time for the logo because we're trying to develop a website. So we couldn't wait until this meeting. So we ended up putting out a survey with ideas of the logo. And so thank you to those who voted on that. We've been working with JJN Multimedia to develop the logo and branding guidelines for our coalition. So in our post-meeting follow-up, we will distribute the branding standards document that we've developed. And we're now excited to unveil the final logo design. And this is it. We love it. So thank you again to those of you that voted on the option. We do have they have, from the branding guideline, how it looks on black and white, just different ways of using it. So we're really excited about that. We'll let people look at it and give them a few minutes to
let them take it all in.
Take it all in. Take in all those colors. We wanted to do green for, food, produce. So yeah, we're really excited about it.
Seen a lot of good reactions in the chat, on the screen. So thanks, everyone.
Yes, thank you.
All right. Go ahead and move us along.
Yeah, so next we're going to have Dr. Carol Greco, and she is the co-founder of Pharmacy West Virginia, and she's going to talk about their Pharmacy West Virginia program. So Dr. Greco, turn it over to you.
Thanks so much. I appreciate being selected to do the spotlight today. Pharmacy West Virginia prescriptions for produce started back in 2016 in Wheeling, West Virginia. We now have about over 30 sites actually in 2025 and over 26 counties in the state. And essentially we started in response to the high rates of chronic disease, chronic diet-related disease that exist in West Virginia. Basically, we have a 4-pillared structure to this program. The first pillar is access to locally grown produce, and we do recruit and we target specifically West Virginia farmers and aggregators in the state. And they supply for 15 weeks, $25 per patient per week of fresh produce. The second pillar is a basic standardized education in both nutrition and culinary skills. And up until this point, we had solely had the WVU Extension, FNEP, and SNAP-Ed providing this education. And of course, we all know that that is going to not exist as of September 30th. So we are continuing to explore ways of providing this standardized education in 2026. The third pillar is biometric and health metric collection of data. And since we target patients with type 2 diabetes and food insecurity, we basically do blood work, hemoglobin A1Cs, and lipid profiles, which of course are diabetic markers, pre and post program, as well as pre and post surveys to monitor the patient over that 15-week program and see how they've progressed. We also include the hunger vital signs in those surveys. We have partnered with the WVU OHSR, the Offices of Health Services Research, over the years. They have assisted us with data collection, standardized data collection. The last 2 years, we used the REDCap software system to do this. OHSR provides IT support for all of our sites. They provide training, they provide registration for the REDCap system, and really we couldn't exist without them. We have at this point 5 years of solid data as of the end of 2025, 5 years of solid data showing significant impact in all of the biometric indices that we collect. OHSR also sends individual dashboards to all the participating sites at the end of the year, and they provide a statewide report at the end of the year for us to look at to see how we've done. Our fourth pillar, and we think this is probably the most important pillar for continuation and sustainability of the program, is a strong patient-provider relationship. The medical provider can be a physician, a nurse practitioner, physician's assistant, or even a nurse in the clinic that has a relationship with the patient and knows the patient intimately. We know that patients need support through this program, and they need support after the completion of this program. They need continued affirmation and accountability as they progress on their wellness journey. So it's really important to have some type of a relationship with a medical provider. We also know that providers need education, and our team works to help to support this education and educate providers as needed. We contract with FQHCs, hospital systems, and private physician offices, and they provide the location or the site for the program, and they also provide the patient participants. And we find the local growers and aggregators to supply the 15 weeks of fresh produce for the program. And our team really works to coordinate all of these pieces to provide and support a viable program. Pharmacy West Virginia has been supported by grants from several MCOs, most recently Aetna for the 2024 year and 2025 year. We've also been supported in the past from Walmart grants, the Department of Ag, and other multiple private philanthropic groups that exist in and out of the state. We've had really good partnerships with the Department of Ag and with the West Virginia Farmers Market Association. They've helped us over the years to develop a viable program in many different ways. They've helped with fiscal partnerships and also with developing a planning guide for farmers and helping us to locate farmers for the program. So that's pretty much it in a nutshell. That was a lot in a short period of time, but wanted to refer you to the website, pharmacywv.com, FARMACYWV.com. We've got a lot of information on there, which expands on what I just said. We've got a how-to of the program. We've got a history and process, and and also a lot of videos with testimonials and advertisements and all that good stuff. So, if you have a chance, look at our website for a lot more information. And thanks so much again. We appreciate being able to talk about pharmacy. Any questions, please just throw them in the chat.
Took the words right out of my mouth. All right, if folks have questions as we go along, again, always feel free to use the chat, but I'm going to go ahead and move us along in our scheduled programming. And I'm going to turn it over to my colleague, Mark.
Hi, everybody. Great to be with you. I am Mark Humowicki. I lead the Camden Coalition's National Center for Complex Health and Social Needs. I work with Ryan and Lon on this initiative. So I'm here today to talk about some of the other work that I do with other clients and partners around the country and what we've learned from this relatively new model of community care hubs that has been sort of expanding of late as sort of a FYI, like wanting to put some information out for the coalition to learn about, ask questions about, and consider as we go into the September strategic planning retreat. This is by no means the next step of the coalition is to build a community care hub. I don't think that would be, that's not at all what we're suggesting, but wanted to get some information and help to frame some of the conversations as we start to talk about what types of activities as a coalition we want to be engaged in. So, next slide. We've tried to stay a bit in the background. This is really like a West Virginia-led coalition, and we're just sort of extra hands and advisors. This is a little bit about the Camden Coalition's National Center, which has been in existence for coming up on 10 years, and really tries to build the field of complex care, which really sits at the intersection of healthcare and non-medical services. Social care is often described as. So, right where food is medicine sits, right? The relationship between things that are not usually considered healthcare interventions, but are really important to the health and well-being of individuals that interface with the healthcare system, and how do we sort of introduce interventions, approaches in ways that are efficient, effective, sustainable, and scalable. So we do a lot of teaching, training, consulting, technical assistance. We run a conference every year. It looks like we'll have 850 people out in Portland, Oregon. We've got the National Food is Medicine Coalition presenting on their sort of national policy strategy. At that meeting, we've got probably 100 plus folks who work for community care hubs, many in the state of Washington, but others in New York and other states around the country who will be there. So we sort of live and swim in this space of community care hubs. So that's just so you know where I'm coming from. I'm part of a group called the Partnership to Align Social Care, which has been in existence now for 3.5 years. It's a learning and action network really focused on advancing the community care hub model. And I lead the contracting work group and have been on their strategic advisory committee since the beginning. And I'll also have been a contractor and sort of written a lot of the resources that I'll be referencing in the last slide. So I'm a little biased towards community care hubs. So take all of this with that grain of salt. Next slide. So, when we think about the Food is Medicine Coalition, right, the sort of draft mission and vision is about really making sure that all people that have diet-connected diseases have access to healthy, nutritious food, and really trying to expand the availability of food as medicine type of interventions across the state of West Virginia. As you heard from Dr. Greco, pharmacy has been doing that in very significant ways with grant funding from, and she mentioned a wide range of philanthropic supporters, but I'm sure she would acknowledge that there's more need than there are grant dollars at any moment. I think the collective goal is how do we really grow the food as medicine infrastructure in the state to be able to meet the statewide need. And what we're seeing in a lot of places, and it's maybe a little bit harder to say in the last 8 months than it was prior to 2025, but there was a lot of momentum around healthcare financing of non-medical interventions like food as medicine because of the evidence showing that healthy food or housing or transportation or other things, particularly for high risk, high cost populations, have a positive financial return on investment in healthcare. And so what we're seeing in lots of places, and we've been doing a ton of work in California, but also in New York, Massachusetts, other states, is this sort of move towards folks who weren't traditional healthcare providers contracting now with Medicaid, and really in most states, and in West Virginia's included, Medicaid managed care, and having service contracts where they are providing a service like a medically tailored meal or a nutritious food box or other service in exchange for a payment. And, it's a very different model than most folks in the, nutrition and food space are used to. We're typically used to grants, and there are different requirements when you are contracting with healthcare. And, there are folks on this call who could probably describe some of this better than me, like Jordan at Aetna. But, when you're contracting with healthcare, and I'll say, like, my other job at the Camden Coalition is general counsel. I'm a lawyer. So I have done contracting with Aetna and United and our state Blue Cross. So I've dealt with this for our own organization. And these are the things that you need to be able to do as a contracted provider to a managed care plan. You need to be able to engage in business development and contracting, negotiation of contracts, review of contracts, et cetera, et cetera. So there's like a legal component, there's a business component. Once you have a contract, you need to be able to administer and fulfill that contract. Typically, there are standards associated with the contracts, there are deliverables. There are, they don't just go perfectly. So there's problem solving associated with managing contracted relationships. There's lots of work on the administration side. There's compliance that needs to happen in order for a managed care plan who is a highly regulated entity by the feds, by the state, to be able to feel comfortable paying and sharing data with another entity. So you need to have insurance, you need to have privacy protections, HIPAA, you need to have various policies, procedures. Now there's a lot of focus on fraud, waste, and abuse, so you need to make sure those programs are all in place. So compliance is a big thing. IT systems to be able to connect between the health system, the provider, the healthcare provider, the food provider, all of that needs to be sort of in place. Revenue cycle, if you're billing for claims or you're billing for some sort of way, even invoices, has various steps associated with it, referred broadly to as revenue cycle. making sure people are eligible for the benefit, enrolling, providing the service, submitting the claim, reconciling if the claim is denied for some reason. There's a lot of work that goes into that. Making sure you have a closed loop referral process, both the workflows and the IT system. Those are typically going to be requirements for healthcare to say, yeah, we're going to contract with you to do a benefit or service like this. And then there are other aspects that are important for healthcare, like they typically don't want to contract county by county with 30 different providers, because that's a lot of work. They love a single contract that can be easily administered because that's a lot of work if you have to have multiple contracts. The part of the first bullet really is about making sure that you have statewide coverage, because there are rules that they're subject to about sort of uniformity of coverage and having your typical services. They have requirements around their network, known as network adequacy. So if this starts to become a formal benefit, you need to have the benefit available to everyone. You can't discriminate against people that are in certain regions of the state, etc. Having standardized eligibility, services, and quality, managed care, that's just sort of how they do things. Scale and efficiency, quality improvement, all of these are things that healthcare would be looking for. Let me just stop there, since we do have folks like Jordan and others who are from the health plan world. Am I missing anything or getting anything wrong here? Not to put you on the spot, Jordan. I know you're like both muted and off camera, so you may not be in a position to talk. But if there's anyone from that even has experience in their past in the health plan world. And if not, that's okay.
Can I ask a question? Is that like a time for that,
Of
or I
course.
can wait?
Yeah,
Awesome.
go for it.
So when it says regional statewide coverage, because I understand you're saying one contract, I get like that is cool. When it says regional statewide coverage, to keep it like fair and equitable, like if it's offered here, it's offered there. Like sometimes I gotta drive because I'm rural. I gotta drive an hour and a half or 2 hours to see the dentist.
Yeah.
So if someone has to drive an hour or two to receive this service, am I still offering it like regional, even though like I have this hub and you're coming to this hub?
Yeah. Good question. And I'm not a network adequacy expert by any stretch, and how it's being applied in these new services. Like, Ryan and Lon both do work with our teams in California, where they were rolling out county by county new food benefits. And some of the counties, the managed care plans adopted them sooner than others. It was made optional. And yeah, I mean, dentists, like these requirements are where like theory hits reality. Like the state Medicaid office can't mandate the creation of a dentist in a rural area where one doesn't live. We're not in a position to like, force someone to go live in this underrepresented area. So how that works from a food is medicine standpoint, but and that's why like the left side is requirements. The right side is more like nice to have, beneficial, but not required. And sometimes it's not going to happen. And this is really, again, this is often iterative. I do a lot of work helping non-medical providers develop contracts, get ready to provide services to managed care plans. And they don't have their entire compliance program, like the gold standard of compliance programs in place on day one. They're developing it iteratively over time, little by little. And that's what we did. I mean, I'm our chief compliance officer as well. And over the last 8 years, we keep adding elements to our compliance program. So, the idea is not that you have to have everything in place before you can approach a managed care plan about a contract. But these are things that you will need to be thinking about and that they will be pushing you to develop. And so like there's a local food as medicine provider called Manna here in Philadelphia that I've gotten to know their leaders pretty well. And they've been contracting with local Medicaid managed care plans for 10 years now. And it was the same kind of thing where the first contract was a pilot and they didn't have a lot of the stuff that they have in place now then. And it became a partnership of like, how do we build this? How do we build the IT? How do we build the evidence? How do we build the revenue cycle management? So I just wanted to give a sense of the kinds of things that become relevant in contracting with healthcare, with an eye towards, as you'll see in the next slides, that community care hubs are one approach to trying to provide those efficiently so that not every small organization that's involved in food as medicine has to build all of these things for themselves, that we can have shared infrastructure. So let's go to the next slide. Thanks, Shane. Appreciate the question and
Thank you.
the thumbs up and all of that. So here's a definition of community care hub, right? I'll let you read it. You know, the sort of bold are the key elements, right? A network of community-based organizations that are providing these needs, centralizing administrative functions and operational infrastructure, a lot of the stuff that was on my last slide. And then the second part is really important. Trusted relationship with and understands the capacities of local organizations, community-based and healthcare organizations, cross-sector collaboration, community governance, authentic local voices. Looks a lot like the values, mission, and vision of this coalition, right? Y'all are in line with the philosophy of the community care hub. Next slide. So like I said, this has been gaining steam. 15 years ago, there were probably 2 or 3 community care hubs that were stood up with some grants from John A. Hartford Foundation, which is a national foundation focused on the aging population. Area agencies on aging are, you know, a standard infrastructure in every state. Every community has to be covered by a AAA. Sometimes they're part of government. Sometimes they're independent community-based organizations, 501c3s. But a lot of them have, in various places, AAAs have come together to form these community care hubs to be able to provide the Meals on Wheels and the care transitions and other types of services that they provide using Older American Act funding to beneficiaries of Medicare Advantage programs or Medicaid long-term services and supports programs. So they've decided that like that Older American Act funding is not enough to meet the needs of their aging population in their community. And we can supplement that with healthcare funding if we can compete, if we can organize in a way to compete for contracts. And that's what they've done. So here we have a map. This just came out at the US Aging Conference in July that I was at. 70 plus community care hubs. Some are regional, some are statewide, some are multi-state. Most are multi-service. I don't know that there are any food as medicine community care hubs. They often are doing care coordination. They're doing lots of services. So that's something for us to think about if we are thinking about community care hub as an infrastructure. Should it be solely focused on food as medicine, or is there room for it to support other lines of service, et cetera, et cetera? There's been, like I said, an acceleration of adoption in part because it's become a specific named priority of the Administration for Community Living, which used to be the Administration for Aging and the Administration of Disability, and then got folded into ACL, and soon in 2026 will be folded into a whole new Children, Families and Community Administration, because that was part of the HHS restructuring. But the ACL leadership that has been working on this for 6 or 7 years continues to be in place and continues to push this out. So they gave a grant a couple years ago to US Aging to build a center of excellence focused on creating and advancing community care hubs. I'm on that advisory committee. I'm also a TA provider to that group. So that's part of why I was at US Aging presenting and meeting with all of those grantees. I mentioned the partnership to align social care. It's been mentioned in various CMS tools, documents, both under the Biden administration and now under the Trump administration. And there was support in the first Trump administration for community care hubs. So this is a, sort of a bipartisan type of, or nonpartisan type of approach of really, and very much, certainly with food as medicine, community-based, it's very much in keeping with the Make America Healthy Again sort of mantra. And there are states that have said, we want to create community care hubs across our state for Medicaid. So Washington has done that. That's why you see all those pins up in the Pacific Northwest. New York has done that. So there are 9 community care hubs in New York. I'm working with 2 of them now. But some of these have nothing to do with a state strategy and really have grown up organically. And that I think is important to know. And there's a great community of community care hub folks that come together and learn from each other. And so I think there's a lot of opportunities there to that's in some ways the whole point of the partnership to align social care is to pull out all the wisdom of the people that did this first to make it easier for the next group of people to be able to do it and to do it well. Next slide. So here's a visual that we just developed with our friends at the Uncommon Solutions. That's the logo in the bottom right corner. They are a consulting practice that's really similar to the coalition, very mission driven, public health folks coming out of the state of Washington. And we are really thinking about how do we make sure this is successful nationally. And there is a risk of starting a bunch of community care hubs that aren't able to financially sustain themselves. So you start something and then it folds after a couple of years because it just can't generate the revenue. So no one is suggesting launching a community care hub willy-nilly. There has to be a lot of rigorous sort of assessment and making sure that this is the right strategy and that there's potential revenue to be able to support it. But this is sort of a visual to represent the role of the community care hub in an ecosystem in like a state or a region of a state. So the idea is you have referring partners, that you have folks who are, screening for health-related social needs, identifying people that have a need, and referring them into the hub. The hub has a network of providers that are contracted through it, that are in the different regions and are able to have staff that are funded through the hub or through the contracts and are able to provide, to work directly with clients. But the hub is doing a lot of the heavy lifting of that slide that I showed about what does it take to contract with healthcare. So they're providing that in that white middle space of the hub of the circle, that CCH infrastructure, the IT infrastructure, the data security to be HIPAA compliant, the data performance and impact to be able to show to payers, this is working, you should keep investing in it. The measurement, monitoring, and reporting to be able to keep making improvements to the program. The community engagement to both have the network, to be able to understand at the local level who needs to be involved, what improvements need to be made, that it is truly locally sort of governed. The service standards to make sure we're doing evidence-based food as medicine, TA and workforce development to bring those who may be newer as providers or as workforce along to be able to provide the best quality services, contracts and compliance, billing and payment. So all of that are capacities that a community care hub could and often does develop to be able to provide value and support to their network of other community-based organizations, other groups who provide the services, but don't have to think about developing all this new healthcare specific infrastructure. And this, this is designed around engage, assess, support, connect. When you have multi-services, when you have access to food benefits and housing benefits and transportation and care management benefits, you really can be, a community care hub can be more of a one-stop shop. It's often having to both refer people to funded benefits that come through the managed care plan contract, but also other benefits that may be funded by federal block grants, state grants, et cetera, that exist in our communities. So they really need to be experts in sort of all the services that are available. So this is the general vision of what a CCH is. And again, if the Food is Medicine, West Virginia Food is Medicine Coalition were to decide we want to pursue something like this, it might look like this, but different in certain ways. There's nothing wrong with that, but this is just try to give you a sense of how this all works. Let's keep going. I want to make sure there's plenty of time for other questions. This really gets into the details. I'm not going to go through line by line. When you start to think about what does it mean to be a community care hub, there's a lot of stuff. Like these are the functions, and we've grouped them in these 4 categories of strategy and governance. Like a hub needs to be able to have the buy-in of all of these different groups. It needs to have the infrastructure and the strategy to be sustainable. And so there's a lot that goes into to leading a community care hub on behalf of a network. And that's largely that first bullet of strategy and governance. Then there's the business and technology infrastructure. We've talked about a lot of those different components. The data performance and impact. Really, this comes back to the fact that healthcare paying for these types of services is relatively new. And in order for it to continue and sustain, we can't ignore data. We have to data is our best friend in terms of making the case for the impact that this has on the well-being of people in West Virginia who are beneficiaries of health plans and who are, this should be saving health plans money, and that should be part of why they invest in it. They also invest in it because it's the right thing to do and because they know that it's good, but also because it saves them money. And then social care network management, like all the groups that are actually providing the services as part of the network have needs and need to be supported. And so there needs to be staffing and infrastructure to be able to lend them support and not just say, oh yeah, and then there's 3 other things you need to do for us. Good luck. We'll be checking up on you. So being a community care hub is no small task. It takes dedicated staff. We've been helping groups to get these off the ground. We're working in Long Island right now, in New York, with a community care hub that has 150 members in its network. It's enormous. It's at times overwhelming. And so they are at that size and scale because New York State said, as part of its 1115 waiver, we're going to stand up community care hubs in every part of the state, and they're going to screen every Medicaid beneficiary for health-related social needs, and they're going to navigate to enhance services certain defined populations. So that, gave them a really strong mandate. They got a lot of money to do it. They had to do it on a very, very fast timeline. That's not the case here in West Virginia. We don't have that money and we don't have that mandate. So it's a blessing and a curse. Like we're going to have to really figure out the financing side, but you also have the time to figure out, is this what we want? Is this what makes sense for West Virginia? Is there some other way to sort of solve the contracting or even the scaling of food as medicine problem? Maybe it's not a healthcare contracting. Maybe there's a different model. Maybe there's a social impact bond model or a larger grant model or some other state funding model. But if healthcare contracting is part of the long-term revenue sustainability strategy for scaling of food as medicine, this is meant to be that sort of an overview of that. And community care hubs can help to deal with some of the administrative burden. Next slide. Laura Phillips, you get the gold prize here. Your question, if you like, is the question that motivates this slide, considerations. And we are actually putting the finishing touches on a brief that goes right into this. The brief is going to be, we don't have a snappy title. If anyone has any ideas as I describe it, please put it in the chat. And we'll give you a gold prize. But it's basically on what is the right corporate structure for your community care hub. People do it as both. They do it as within existing organizations, either as just a new program, like if the Cameron Coalition were to do this in New Jersey, and honestly, we thought about it for a little while, is there new housing benefits in New Jersey Medicaid? We said, okay, we could stand up a community care hub. It would just be another program. And we would take one of our current leaders and put them in charge of it, and they would build it up. And we'd still have the same board. We might create an advisory committee and some other infrastructure to manage the development of the community care hub, but it would sit inside of our existing org because we have so much of the infrastructure that I've already talked about in terms of IT and compliance and financial and care management and all of that. Other places decide to create a new organization. Sometimes it's done as a joint venture. In Houston, Texas, there's the it's Harris County Department of Health joined with a local foundation that was really committed to this with a academic medical center. And the three of them said, none of us can do this alone, but we all want it done. Let's create a new entity. And they hired an executive director with some grant funding to start this community care hub. That executive director isn't able to do everything that was on my previous slides all by themselves. Each of those three partners is contributing sort of in-kind resources, access to a data analyst from the Department of Health, access to an IT system that the academic medical center has, et cetera, et cetera. So sometimes you could start a new organization, but you've got sort of founding partners who are contributing in-kind services. And then in Western New York, there were 7 AAAs that all came together and said, let's work on this together. Those 7 AAAs became the board. They hired an executive director, new organization. And then every time they've been adding members, and those members are now members of a membership organization and have the opportunity to sit on the board. So not all, I think they have 70 members, not all 70 members sit on the board, but some selection of those 70 members sit on the board. And with the 1115 funding in New York State, they've been able to scale. But for a while, it was like one woman, like a registered dietitian who had experience with the aging network, who was phenomenal, who ran this thing basically as a one-woman show with the support of these 7 AAAs, and they were getting contracts and so forth. So there's lots of different ways that you might run it. These are the sort of questions in our decision matrix model that we're putting together for this brief. First question, is there even the money to be able to justify building a CCH? If there's not viable business opportunities where there's enough revenue to earn, then we shouldn't be building it because it won't succeed. And then, is there an appetite for CCH? Are these different organizations across a region, across the state, willing to come together under a single network, or are they competing with each other too much and they're not willing to collaborate? Is there an existing community care hub that you could join? There's a great community care hub in Virginia that has a ton of capacity. Would it make sense to talk to them to see if any of their capacity could be extended into West Virginia? I don't know, maybe. So is there an existing organization that's doing something like this? I saw one of our members today, who I'm looking forward to getting to know in September, who works for the Hub. Now, I looked it up on the web, and the Hub, I guess, is a community development hub, so slightly different hub, and may not be positioned to do this, but like that's part of the landscape, is like looking at all the different entities in West Virginia to see who might be positioned to be able to play this role. Is this a role that the Extension Center could play? Is this a role that, Facing Hunger could play? Like various groups, that's part of the analysis. That's number 4. Is there an existing organization that could host a community care hub? So those are sort of the questions that we would ask. This is getting ahead of ourselves because we don't even know if this makes sense, but this is sort of projecting what kinds of questions you might ask before endeavoring to build a community care hub. Next slide. And this is really getting ahead of ourselves. This is the market assessment. So that first step of like, how do you assess whether there's enough revenue opportunity? These are components of doing a market assessment to really understand, are there viable business opportunities? These are the components of it. This is the other brief that we are finishing and will be publishing in the next 2 months for the Partnership to Align Social Care, how to do one of these market assessments. So, like I said, lots of resources out there for folks on community care hubs. Let's go to the last slide. You can see all these resources that exist. Many of these we've written, but others at the partnership have written others of these. That first bullet has a whole resource tab with tons of information. I run a monthly group. It's a little cheesy. It's called Coffee and Contracts. But every month people get on and talk about different topics related to social care, healthcare integration, often around contracting, but also around other aspects of community care hubs. Ryan was supporting that for a while until he got too busy with other projects. But so this is something we spend a lot of time thinking about. So I'm happy to answer any questions. I don't know what else is on our agenda, Ryan. I'm sorry. I'm sure I went over. So how much
You're
time do
fine.
we have for questions?
We have about 5 minutes for questions.
Okay. Why don't you take down the slides so we can see everybody? I hope this wasn't overwhelming. It was not intended to be scary, but really just to sort of whet the appetite to think about other structures.
So Mark, as soon as you started talking about some of these community hubs and regionally and ability to touch all aspects of the state, I immediately went to our family support centers and FRNs that are in the state. They're administered by DHOS. So also what you were talking about with CMS and HHS at the national level, kind of buying into this, that could be the source of that funding. If the federal government would give the state more money to put out to the FSCs, FRNs, I think there's a possibility that could collaborate. I think that there's avenues to do that, minus a few of the things like the IT infrastructure and stuff like that. I don't know that FRNs and FSCs can support that. But some of the other types of like community needs assessments and working with the community case management, they're already doing a lot of that work.
That's awesome. So how many FRNs are there and who are they?
So the FRNs and FSCs are different, but they work together. Okay. Each of the 55 counties has a family support center, and a couple have 2. Okay. So it's statewide.
And so are each of those separate organizations, or?
They operate independently. There are a few that are kind of under a financial umbrella of one
Okay.
organization, but they all operate their own.
Wow. Okay, cool.
But yeah, that's under the guidance of the Department of Health
Yep.
or Human Services.
Great. Would be good to learn more about that. Other questions that folks have? Laura, you really nailed it in terms of your comment in the chat. Like, that is exactly the goal of having CBOs focus on services and have sort of one entity really know the administration and have the relationship with Jordan and everybody else to really be their business partner. So when Jordan's thinking like, oh, this, we're seeing this stuff come down from CMS or from West Virginia Department of Human Services or whoever is the Medicaid office in West Virginia, he's calling the hub to say like, this is what's coming down the pike. How do we adjust what we're doing to be in compliance with this new policy direction coming out of Washington or coming out of Wheeling? Where's your capital? I know this. Where's your capital? This is embarrassing.
Charleston.
Charleston, of course. Jesus.
Okay, you're
I'm
not from West
sorry. That's like
Virginia. It's okay.
major faux pas. Oh. Go for it, Laura.
Well, I was going to say, but maybe it was too long past, but I think Wheeling was once tossed around as a capital for West Virginia. So you're not too
Thank
far
you.
out there. You're just back
Oh,
in the,
I
history.
mean,
It was the
Um,
capital, yeah, at one point.
Yeah. Oh, was it? Okay. There we go.
Yeah.
So, well, I guess in related like to community care hubs, like my wheels are turning, like what kind of, I guess it just depends on the region that you're trying to cover, but like what, and starting one up and like sustaining something, you have to have like probably a large pot of money, or there has to be some sort of like either like that large sustainable funding to even think about like planning for one and getting kind of all the details in place.
yes, and I mean, I think there's no reason that this group couldn't start, that we couldn't support starting to do some of the thinking about it, some of the like, would doesn't make sense to start building, hiring people, that kind of thing. But this coalition has so far been a very much a working coalition where people are putting in time and energy. And so to the extent that folks have time and energy to invest in this, I have at our disposal dozens of community care hub leaders and dozens of examples of different flavors of community care hubs. So if we wanted to bring to a future meeting a couple of people from community care hubs to be able to just do a brief presentation on their hub and answer a million questions about how they got started, we could do that. That would be easy. So but yeah, that's part of why like ACL created the Center of Excellence. They gave US Aging $12 million and required that 10 of those $1 million had to go out as grants to the grantees to community care hubs, and the other 2 million was spent on administering the program over 3 years. So it actually has been a fairly lean program, but they gave grants to 20 different organizations, and then they run this learning community. So and that's something that is just volunteer. So like if people here, if there's one or more people that wanted to like start to attend the learning community around community care hubs that ACL has, or My Coffee and Contracts mean all of these things are free and open to the public, and we would welcome participation. So, I think that may be premature, but if this would like make you happy, like this is something that you would want to devote your own time to and you could justify, there's no reason not to. I think there's a lot of it's a lot of time and learning. I think one of the challenging things is because it is a big undertaking investment, but often the opportunity comes relatively quickly. It's hard to manage that like balance between getting ready without spending money because we don't have the money to spend, but then being ready to move quickly when the opportunity arises. And that can be really hard. But, the creation of this sort of coalition and thinking about this and having partners who are working together and having these conversations is a good way to lay that groundwork and, sort of fertilize the soil, etc. I'm a city boy, so I should not be using agricultural metaphors, but
And we have 3 minutes. So Ryan, I think you need to go over
Yep.
the agenda for
Let's,
yeah. Sorry to cut.
oh, sorry, yeah.
Sorry to cut-
Can we
yeah.
have the September meeting?
We've got to do
so we want to take a few minutes and talk about our in-person meeting in September on September 18th. And we're going to put up the logistical details for that in just a second, but we want to preview our agenda, and this is going to go out in our follow-up email. We'll have a sort of like open comment period for folks to review this proposed agenda, reflect, ask questions. But broad strokes, I'm going to leave it up on the screen. I won't read it verbatim. I'm just going to talk thematically about what folks can expect in September. We are going to have an optional 8:30 build connections over coffee talk, is what I called it before I remembered the SNL sketch, if anyone remembers that. But anyway, so we are kicking off at 9, and then we will have first a discussion about the landscape, and we're also building in a lived experience panel on this, so we can sort of review the available data and the policy landscape, but then also more importantly, hear from people about their lived experience and sort of accessing these programs, what it's like to live with the health and social needs that we're all working tirelessly to address. And we're front loading the agenda with a lot of the sort of talking at you parts, so we can emphasize small group discussions through the rest of the day. So we can focus on these sort of like no wrong answer, idea generation, building solutions, but also most importantly, building connections. So we are going to take a look at national and state food as medicine coalition models in the morning. We have a working lunch where we're going to sort of talk about the coalition's vision. We're going to workshop ideas and talk about our purpose and role as an organization. But then also you'll see we have a dedicated section for member spotlights. We're going to solicit programs to come to the meeting and talk about their services and programs so we can learn more about the work that we're doing. We have dedicated small group thematic discussions, which we'll share more about, and also what we're calling speed networking, so we can focus on building closer relationships with each other. And that's really what we're trying to accomplish in this in-person meeting. I know we're at 3 o'clock, but what we really want to emphasize here is so we can all learn about the fabulous work that everyone's doing across the state and start learning more about it so we can sort of be great partners and evangelizers of each other's work. And with that, you can expect a rundown of the details of this agenda and our follow-up, which is going to go out first thing tomorrow morning. And we're going to open that up for questions and comments, and we'll send instructions for that. But we want to make sure that you also have the RSVP information. The link is going to go out. There's a QR code there for those of you who are tech inclined. Thank you, Lon, for setting us up with that. And we do need to have our logistic information for anyone who's requesting hotel rooms squared away by Monday. So we are getting close to the threshold there. So if you need to spend the night on the 17th to get there early, I know a lot of us are coming for over 2 hours to make this meeting, so we so appreciate the time and effort that takes. We want to try to make as many accommodations as possible. The earlier the better for RSVPs. Gina, do you want to jump in with anything there?
Yeah, I just also wanted to point out that we also have the option, if anyone needs a room for the 18th, we do have that option in the contract with Stonewall. We can't support 2 nights per person, but if you needed a night on the 18th after the meeting was over, we can support that. So yeah, just we have a couple of options there, and we do have plenty of rooms available still. So
perfect.
Thanks, Ryan.
Thank you, Gina. So we hope to see you all there, for those of you who can make it. Really appreciate everyone's time and energy today. So thank you for a generative discussion, great meeting, and I hope to see you all in September. Thank you.